This is Selma Schimmel for the Group Room at the ESMO 2012 Congress happening now in Vienna. And now we are joined by Professor Michele Ghielmini, who is a professor at the University of Bern and medical director of the Oncology Institute of Southern Switzerland. Welcome, Professor.
Hello.
How do you decide when to treat, when to wait to treat, the watchful waiting that is unique for lymphoma patients and in some ways psychologically challenging too?
This we don't do for every lymphoma. This we propose only to patients who do not have symptoms of their disease, who have found their lymphoma just by chance, and who are bearing a lymphoma who has a very good prognosis. Like, for example, a good risk for follicular lymphoma. We know that these patients are going to live for 14, 20 years, and or chronic lymphocytic leukemia, or marginal zone lymphomas, or other who have a very long lifespan in front of them. So we don't want to interfere with the quality of life of this patient. They have a disease, they don't feel it, it was found by chance, and they don't suffer of this disease. And we also know that if the treatment is started now, or it started in 2 years, or in 5 years, or at any time where it starts producing symptoms, this will not impair on the duration of life. So you live the same life and the same duration of life that treatment is started today or in 5 years from now. So, of course, you don't only have to wait, but you also have to watch. This is why it's called watchful waiting. And so these patients have to come in every 3 or 4 months. They have to be checked, do blood count, be visited by the doctor. And if this is done, there is no risk, and the patients can live a normal life until it becomes necessary to start a treatment.
What is today's standard of care?
If the patient cannot stand to wait, if too anxious to wait, and he wants to do something for his disease, or if the doctor, sometimes this happens as well, the doctor is too anxious to wait, well then single agent rituximab is the treatment to be given. It has very little side effects. It works in about 80% of the cases. The disease disappears. And it was also shown from these studies that the right way of giving rituximab is to give 1 month of rituximab, so once a week for 4 weeks, and then stop. And then after a few years, the disease might come back, and at this time you can retreat the patient with 1 month of rituximab again, and you can do that several times before it's time to start chemotherapy. But this you can only do in some types of lymphoma, which are mainly the marginal zone lymphoma and the follicular lymphomas.
What is the role of bone marrow transplant?
Well, we must distinguish between autologous bone marrow transplant and allogeneic bone marrow transplant. So normally when people talk about bone marrow transplant, they mean allogeneic bone marrow transplant, so a transplant from a donor. Now, the treatment of lymphoma is, has many options available. So there are many drugs that can be used, and so you can give a patient a first-line treatment, a second-line treatment, a third-line treatment, and then there is also high-dose chemotherapy with autologous stem cell transplantation. This works well. And in the majority of cases, allogeneic stem cell transplantation is used only when patients have failed autologous stem cell transplantation. So usually you give a first-line treatment, and then at a certain point during disease evolution, you will get to autologous stem cell transplant. And if the patient fails autologous stem cell transplant and is fit enough and young enough, then you propose allogeneic stem cell transplantation. This is a disease that has chances of cure, but it is not a disease, sorry, it is a treatment that has good chances of cure, but it is also a treatment that is very dangerous. There is, depending on the conditions, 20 to 40% of patients who die of the transplant, and so it is really something to be used only in extreme situations.
What can you share with us about the issues unique to young adults?
The problem we have with young people is more concerning the long-term side effects. For example, Hodgkin's lymphoma patients, they live very many decades, but unfortunately the treatment they had decades later It can produce side effects like second tumor, secondary leukemias, secondary cancer, heart problems, lung problems, and this is why we need new drugs even in a curable disease, because we want drugs that do not produce these long-term effects when they are 50 or 60.
What do we know about the genetic predisposition? Is there any in the area of lymphoma?
Well, it is not really proven that there is a genetic predisposition. There is also no agent or no condition that has demonstrated to increase the risk of lymphoma. Maybe radiation, but it's not even sure. Despite of this, there are some families in which there is a higher incidence of lymphomas. This is particularly true, for example, for Waldenström macroglobulinemia or for some other indolent lymphomas. For some reasons, there are some families who have more cases, so there is a suspicion that they might be bearing a predisposing gene, but this gene has not been found yet. So overall, I would say that we don't know where it comes from, and there is no known predisposing factor.
Thank you. Thank you so much. Professor Michele Ghielmini, who is a professor at the University of Bern, medical director of the Oncology Institute of Southern Switzerland. Thank you for giving us an update and a bird's eye view into your world of hematology here at ESMO.
Thank you.